All right, good morning, ladies and gentlemen. Let's get started. So just a couple of housekeeping things. Just a reminder to please complete the lecture capture survey so I can figure out or get some feedback on how y'all are using them or not using them. That'd be awesome. My office hours next week are switched from the Tuesday 2 till 5 section to Monday 11 till 2, okay? And if you can't come during those time periods, then give me a holler and I'll try to find a little time during the week that we can meet up. And the material for test 2 coming up, this is Thursday, coming up next Thursday, will be from the material you haven't been tested on, which I think was October 4th. So we did a lot of the cardiovascular mechanics stuff, which hasn't been tested on yet. So we'll start the material there, and then all the way up to what we get to on Friday. Okay, we'll just stop it there in terms of material that's fair game for test 2. Okay? Are there any questions about any of those things? Any concerns? Good? Okay, cool. So then let's jump back into the material. We left off on Tuesday thinking about, we had been through how we get airflow into the system, and then of course the whole respiratory system was built in order to get airflow in close proximity with blood flow. Okay, so we've dealt with the airflow side of things. Now we need to think about the blood flow side of things. We talked about 2 blood flows, 2 circulations within the pulmonary system. Okay, one which is just part of the systemic circulation, so what's called the bronchial circulation. So this is just circulation coming off of the aorta, a vascular bed coming off the aorta, feeding the structures within the vasculature, so feeding the trachea, feeding the bronchioles, those types of things. So that is just a normal vascular bed that we had been dealing with in our last section. So we're not going to talk about that anymore. All right, because you already know a whole lot about how that's regulated. Okay, it's your classic arteriolar vasculature, which can vasoconstrict, your capillary bed, which can cause fluid flux, et cetera, et cetera. So you know an awful lot about that circulation already. The pulmonary circulation, though, is the circulation that goes by the alveoli. Okay, so our pulmonary capillary bed. Okay, so this one is a little bit different, and we got to pay a little more attention to this one. Okay, so we've already seen that it's a little bit different in the cardiovascular mechanics section, right? When we went ahead and we had an example where we vasoconstricted pulmonary arteries, and we didn't really see that that changed a whole lot. And on the bottom of this is a little example of why it didn't change a whole lot. The resistance in this pulmonary circulation has to be wicked low because of the task at hand. 1 vascular bed, 5.5 liters of blood, and a low pressure gradient for flow. Okay, so we have to keep resistance very low in order to accommodate that 5.5 liters. Okay? So it's a very elastic vascular bed to begin with. It's a little bit odd, doesn't necessarily reflect what's going on in the systemic system. And we need to explore that a little bit. Okay, so the circulation that we're going to be talking about from now on is going to be that circulation that goes by those alveoli. Okay, so that's the task at hand. All right, so let's think about regulation of the radius. Because obviously flow across that capillary bed is going to be dictated by those arterioles. Okay, so we need to think about the regulation of the vascular radius. And again, because of the way that flow, pressure, and resistance are related, resistance is going to be a huge regulator of flow, very powerful. Resistance was proportional to inverse of the radius to the 4th. Okay, so we're going to be messing with changing radius. So we know we've messed with radius before, neural, endocrine, paracrine. These aren't going to come across as surprises that we have this type of regulation up here as well. Okay, so indeed we do have some neural innervation, so we have some SNS innervation into the smooth muscle cells of the arterioles of this capillary bed, or of this vascular bed. Okay, and if we do increase SNS stimulation, we will vasoconstrict. Again, this maneuver is very similar to the systemic venous system. All right, remember in the systemic venous system when we had sympathetic nervous system innervation, we couldn't constrict it because we also had a high volume, low resistance system on that side as well. So sympathetic nervous system, what it did was change the characteristics of the compartment, right? It changed its pressure volume relationship. It stiffened the wall a little bit, didn't have that spot constriction. Okay, so the sympathetic nervous system seems to change the pulmonary arteries in the same way. Okay, so we will have sympathetic nervous system stimulation. It will cause, quote, vasoconstriction, but it's not really vasoconstriction. It's more of a stiffening of the wall, a changing the pressure volume relationship. And again, that's because we cannot mess with resistance across this bed. Okay? So again, it's more like a stiffening of the wall. Rather than a vasoconstriction. We change its pressure volume relationship. All right, but we don't change resistance too much. So the resistance is minimally affected up here. Both veins and arteries are innervated, but again, we don't have powerful control up here. So we have a little bit of control, but not a whole lot. Okay, so both the veins and the artery and arterioles are innervated, but it's not powerful. We have some parasympathetic nervous system innervation. This would cause vasodilation or a reverse change in the pressure volume relationship, but again, it's not powerful. Can't really think of I can't think of a situation where it would be a great idea to help the body out of a problem by decreasing flow to the lung. Okay, because essentially that would reduce oxygen availability to the body. Right, so there really never is a great reason to vasoconstrict blood flow to the heart. There doesn't seem to be a great reason to cause a restriction in blood flow across the lung. So we do seem to have some innervation, so there's got to be some situation under which changing the pulmonary system is important, but it's not powerful. So because we have the membrane receptor populations, especially for the sympathetic nervous system, so we have that adrenergic population, we will have endocrine control. So circulating epinephrine and norepinephrine will find this membrane receptor population and cause vasoconstriction, but there's also a beta adrenergic membrane receptor population sitting up there that this hormone will find. Okay, so we have both alpha and beta membrane receptor populations causing vasoconstriction then and vasodilation. Right, so circulating epinephrine and norepinephrine will find both of those and at the end of the day, there's really no net effect. Okay, so 2 ways to have no net effect. One would be to have no membrane receptor population there, right? That doesn't seem to be the strategy the body is taken, but it doesn't want a huge effect, so it puts alphas and betas up there equally. So epinephrine and norepinephrine will have a vasoconstrictor effect and a vasodilator effect, so at the end of the day, no net change. Okay, so an interesting case where it looks like we might want a little bit of neural control, but not a whole lot of hormonal control when it comes to epinephrine and norepinephrine. So circulating epinephrine and norepinephrine will have little effect on radius. Okay, so we also have paracrine, we have a control, we have endothelial cells. The whole vasculature is lined with those endothelial cells, and they're releasing products. So they're up in the pulmonary system. They are also releasing products, and they're the ones that we've talked about before. So things like endothelin and prostaglandins. Which can both cause vasoconstriction, and things like nitric oxide, prostacyclins. Will cause vasodilation. So this would then be something in the local environment that endothelial cells would then communicate with smooth muscle cells to change their behavior. Okay? And then there is a little added control here that we haven't seen before, a little bit of local control by what is in the alveoli. So if we have our, say we have a little alveolus here, essentially we have arterioles coming in, the capillary bed wraps around this thing so that you can hardly see it. And in fact, when you look at blood flow in the lung under a microscope, all you can see is this sheet of blood moving over. There are so many capillaries stacked one on top of each other that all you can see is this massive sheet of red blood cells moving. The phenomenon is called sheet flow, and it's because of the massive number of capillaries that we've got up here. But we do have arterioles, right, that are going to control that flow, and there are going to be venules that are in the system, right? So we get the inflow and the outflow here. So depending on what we bring in to that alveolus, we are going to be bringing, that is going to be in very close proximity to some of the arterioles. So that will then affect arterioles if they're close by, right? So depending on what you're breathing in, you can mess with the vasculature or mess with the resistance. So for instance, oxygen is a good example. If we were to increase our alveolar partial pressure of oxygen, so let's say you were to increase your inspired oxygen, we are going to increase O2 in the alveolus. And it's going to cause vasodilation. This is different from other vascular beds. In other vascular beds, high oxygen would cause vasoconstriction. Right? So if I'm in a skeletal muscle and I have low oxygen, that would mean we need more blood flow there. So low oxygen causes vasodilation, and the opposite to that, high oxygen, then causes vasoconstriction. In this system, high oxygen is going to cause vasodilation because if I have an alveolus with high oxygen, I want flow to go there. If I have an alveolus with low oxygen in it, it would be a waste of time to put flow there. So high oxygen, so this vascular system, these arterioles then, have changed either their intracellular membrane receptor for oxygen, their second messenger, or what have you, to respond in the opposite way than any other arterioles in the body, in order to vasodilate to oxygen, and the opposite if we were to that should be increased. If we were to decrease alveolar O2, decrease oxygen in the alveolus. We will see a vasoconstriction of nearby arterioles because it's a waste to have flow go by alveoli that don't have oxygen in them. So this is kind of a way of shunting flow to alveoli with higher oxygen contents. Okay, brilliant. That's exactly what the system is built for. Okay, bringing air with high oxygen in close proximity to the blood. Okay, so that's the local system working at that. Okay, so we can change, in terms of regulation of vascular radius, we can change smooth muscle function. So all of these four examples were going in and changing smooth muscle function, so we were going to get a change in diameter, or a change in stiffening of the vessel wall. But there are other ways then that radius can be changed in these blood vessels because of where we put them. Okay? So our second way of regulating vascular radius is through transmural pressure. Okay? So there are two types of vessels we're going to talk about here. We're still all talking about the pulmonary circulation, but then there are blood vessels that are associated with the alveoli themselves. Okay, so those capillaries wrap tightly around every alveolus. Obviously, their environment, right, in terms of transmural pressure, their environment is going to be that alveolus, right? And that alveolus keeps getting bigger and smaller and bigger and smaller and bigger and smaller. So pressures are going to change very differently by that piece of vasculature than, let's say, some of the larger, what they call extra alveolar vessels, so vessels that are part of the pulmonary circulation but aren't associated with the capillaries directly. So arteries, arterioles, venules, and veins. Okay? So they're not directly associated with the alveoli, but are part of that pulmonary circulation. But, so let's start to talk about them first. What is their everyday? Their everyday is sitting in that thoracic cavity, exposed to the exact same pressures that the alveoli are, right? So every time we changed pleural pressure from -4 to -8 as we were breathing in, right? And we were pulling out that chest wall closer to where it wanted to be, pulling that lung way out, we pulled everything out in 3 dimensions that was there. Okay, so you remember the whole goal of that maneuver of contracting muscle was to pull alveoli out in 3 dimensions, make it bigger, change alveolar pressure on the inside. Brilliant. But if I'm a trachea sitting in there, it got pulled out in 3 dimensions too, right? If I'm an artery sitting in there, it got pulled out in 3 dimensions as well. If I'm a vein, it got pulled out in 3 dimensions as well. So all of the things that we were talking about that were affecting those alveoli, to increase its volume, stretch it out in 3 dimensions, we stretched everything out in 3 dimensions that are sitting there. Okay? We've already had a little bit of discussion on the trachea and how we can pull the trachea open with every breath or every movement that we pull, or every time we pull air in. We're doing that with every tube that's in there. Okay, so every tube that's in there, say this is an artery, we're sitting at rest. We know that the vessel is open, right? So that means it does have a pressure on the inside that's holding the blood vessel open. At rest, it was pleural pressure was -4 centimeters of water, which means that at rest, there's a pressure to pull it in this direction. right? If it was a positive 4 pressure, it would be pushing down on it. It's a negative 4 pressure, so it's pulling back on it, right? So that's every vessel's day at rest when you're not breathing. All right, when you go to inspire, and you go from -4 to -8 centimeters of water, essentially what we do is we pull it out in 3 dimensions like we pulled out every alveoli. Okay? So we're going to increase radius, decrease resistance, increase flow. So every time you breathe in, all of your vessels are experiencing a change in radius and a change in flow. Okay, so if we were at rest and we had our 3 liters sitting in our lungs, okay, the blood vessels would be open, there'd be a certain amount of flow occurring. As you inspire, we increase radius, decrease resistance, increase flow. Okay? And then as you expire, you do the opposite. Decrease radius, increase resistance, decrease flow. Okay, so you are changing flow. This is a cyclical thing, right? Then if at rest you're breathing 12 times a minute, then you're getting increases and decreases and increases and decreases in flow across the system based on transmural pressure. Okay? If you forced expired, you could actually get flow to go down, right? So if you took that 3 liters, so at the end of a breath, so if you're at the end of a breath right now, you can contract muscle in a way to force extra air out. Give it a try. So if you force extra air out, okay? Transmural pressure now in this direction, drop radius, increase resistance, decrease flow, okay? So we can have a forced expiration. Situation where we're going to drop radius, increase resistance, decrease flow. Okay, so that's the world that all of your extra-alveolar blood vessels live in. 12 times a minute at rest, increasing, decreasing flow, okay? Based on a transmural pressure difference. Okay, so now let's think about those alveolar vessels. Right, so these are the capillaries that are, and the blood vessels that are coming very close to each one of those alveoli and wrapping around them. Okay, their world is dealing with a pressure that's changing based on the alveolus. That alveolus itself is increasing its and decreasing and increasing and decreasing and stretching and back and stretching and back. And it's tucked right beside it. Okay? So their world in terms of transmural pressure could actually be to have, as the alveoli get bigger or the pressure gets bigger, to actually impede blood flow because it's pushing on them. Okay? As that alveolus gets bigger, it might actually push on a neighboring blood vessel. Okay? That's going to be a positive transmural pressure, okay, if we're pushing on those vessels. So the environment of a capillary directly associated with the alveolus is a little bit different. So if I've got this capillary and I've got this alveolus, I know I'm getting flow because I've got pressure in the pulmonary artery feeding it. On the other side, pressure in the pulmonary vein. That the environmental pressure, or the transmural pressure here, the environmental pressure when it comes to this capillary is what is pressure in the alveolus. And pressure in the alveolus was going negative and positive, wasn't it? In order for us to breathe in and breathe out. Right? So that environmental pressure is pressure in the alveolus. That transmural pressure is pressure in the alveolus. Okay, so we can have multiple scenarios here. If our pressure in the alveolus is greater than our pressure in the pulmonary artery, that's trouble, right? Because we're going to decrease radius right here, which is going to decrease flow. So if pressure in the pulmonary artery, the alveolus is greater than pressure in the pulmonary artery, and we know that pressure in the pulmonary artery will always be greater than pressure in the pulmonary vein, right? Because we need to get flow. Then you're going to get a scenario where if I've got, I'm going to draw this here, where I can actually collapse this thing, right? If I've got pressure in that pulmonary, or that alveolus got great, it will impinge and close down, right? To the point where it could actually close it. If I actually closed it, I'd get no flow. If pressure in the pulmonary artery was greater than pressure in the alveolus, so that's a good day, but problematic. Pressure in the alveolus is greater than pressure in the pulmonary vein, you get intermittent flow. So you'll get vessels that are open, but then radius tends to drop as we go towards the venous side. Oop, a little smushed alveoli there. So you'll have reduced flow, or it's been also called intermittent flow. So flow that will stop but then start again, stop and then start again. Okay. On a good day, if pressure in the pulmonary artery is greater than pressure in the pulmonary vein, okay, that's what we need for flow, and both of those are greater than pressure in the alveolus, then we have a scenario where the blood vessel is open and we get good flow. So we're going to get continuous flow. And you'll get these different scenarios based on pressure in the alveolus changing. Okay, so that's really what's going to be changing most dramatically here. Okay, what is the pressure in the alveolus then? How is it changing, and how is it affecting nearby vessels? That's all this is basically saying. Okay, so let's hold on to that idea for a minute, because now we need to think about whether there are scenarios where these situations might happen. Okay, so we know that if alveolar pressure were to change and become greater than pulmonary artery pressure, then we are going to reduce flow. Okay, so we know that that's true. So are there scenarios where pressure in the alveolus will be greater than pressure in the pulmonary artery? Okay, or pulmonary arteries. So let's think about that for a minute, and we'll come back to that argument. So, third way of regulating vascular radius is through gravity. Through sitting or standing, okay, so we're going to come up with the same types of issues that we talked about when we talked about pleural pressure and how pleural pressure changes when you go from a prone to an upright position. Okay, and that was when we talked about pulling the weight of the lungs down in that scenario. Well, you have blood in these lungs, and it has a weight as well. So as you sit up, you will pull the weight of the blood down to the bottom of your lungs as well. So you're going to have less blood at the top, more blood at the bottom, okay? So if we think about what that's going to do for us, if we think about we've got a pair of lungs here. We will pull the weight of the blood down to the bottom of the lung, which means pulmonary artery pressure at the bottom of the lung will be greater. There's more volume down there, so there's going to be more pressure down there. Okay, so pulmonary artery pressure, so this is the bottom of the lung, this is the top. So at the bottom, we will have more volume. More volume would equal more pressure, so it's going to be about 34 millimeters of mercury. But we also pull equally blood down on the vein side, right? We don't just pull blood down on the artery side. Blood is going to be pulled down in both the arteries and the veins equally. So our pressure in our pulmonary veins will also go up. So pressure in the pulmonary veins, about 26 millimeters of mercury. Okay, as we go up then, we're going to have less volume, less pressure. Pressure in the pulmonary artery a little higher up, might be 19 millimeters of mercury. But it's also going to be less in the venous side, so pressure in the pulmonary veins, about 11 millimeters of mercury. Okay, the key here is that the pressure gradient for flow across the lung, regardless of where you are in the height of your lung, is going to be the same. The delta is about 8 millimeters of mercury. So there's not going to be a differentiation in flow based on pressures alone. So the pressure gradient for flow across the lung is about 8 millimeters of mercury. So if we think about flow across the lung being dictated by delta P, our delta P isn't changing across the lung based on gravity, right? Because blood got pulled down equally in both the artery and the vein side. Pressures went up equally in the artery and the vein side, so our delta P stayed the same, right? So when it comes to gravity, changing flow because of delta P, there was none, okay? But there was a change in resistance based on this maneuver because the vasculature up in the pulmonary system is much more elastic than normal, right? So we've seen this a couple of times, that the system is much more elastic than normal. So changing volume up there will change radius. And as soon as we change radius, we change resistance and alter flow, okay? So they've got a high pressure at the bottom of the lung. This is going to increase radius. Of the blood vessels at the bottom. Okay, this is going to decrease resistance and increase flow. And this is due to the high elastic nature of the vasculature in the pulmonary system. So this is where the little bit of weirdness about this vasculature starts to have a physiological effect. So essentially what this means then is we are going to have a higher flow at the bottom of the lung. Okay, the higher flow, though, at the bottom of the lung is not due to a pressure gradient issue, it's due to a change in radius. Okay? So we will have a distribution of flow across the lung due to change in radius. But then we also do now suddenly have a range in pressures across the lung, okay? And we did just talk about how changing pressures in relationship to alveolar pressure is going to mess with flow as well. Okay, so we have set up an uneven distribution of pressures. So, second effect here. So due to an uneven distribution, of pressures across the lung, there will be scenarios where pressure in the alveolus is greater than pressure in the pulmonary artery, being greater than pressure in the pulmonary vein. So there's going to be regions based on gravity where this scenario is true. There will also be regions where pressure in the pulmonary artery is greater than pressure in the alveolus is greater than pressure in the pulmonary vein. So places where we're going to get low flow, that intermittent flow, and then places where we're going to get high flow. So pressure in the pulmonary artery greater than pressure. Pulmonary vein is greater than pressure. In the alveolus, we're going to get high flow. So those regions can exist now because we have this distribution of pressures across the lung. Okay, in fact, there's region 1, zone 1, can happen right up at the top. Huge questions as to whether zone 1 or regions of no flow actually occur in humans. So there's a little bit of argument as to whether zone 1 occurs. But we'll give it some props and say maybe up way over at the top it does. Regions in the center, okay, when you're standing, we're going to get regions of lower flow. And then at the bottom is where we're going to experience regions of highest flow, okay? So high flow based on that change in radius, high flow based on the transmural pressure argument, okay? So at the end of the day, when we think about flow in the pulmonary system, and we think about the bottom and the top of the lung. Okay, so blood flow. We talked about airflow already. So if we talked about blood flow, let's make that clear. Talking about blood flow across the pulmonary system. If you were lying down, all of this would go away and we would have this equal blood flow across the entire system. But you stand up or sit, and you get a distribution of blood flow, highest at the bottom, lowest at the top. Which is great, because when you were sitting or standing, there was a distribution of alveolar flow as well, wasn't there? The flow was coming into the alveoli at the bottom, greater than it was the top. Okay? So the system now looks like it's starting to match. Okay? So let's then look at the two together. Let's look at the data for what it looks like when you have blood flow, right? So this is the actual data for blood flow. You see that? I guess you've got a copy. Blood flow across the lung, and in terms of distance across the lung from the bottom to the top, Okay, so this is just the graph that we just thought about. All right, obviously this is when you're sitting or standing. All right, and we have that distribution of blood flow from the top to the bottom. When we talked about airflow or ventilation, alveolar ventilation from the bottom to the top. We had a distribution where we had more air out of every breath coming into the bottom, coming into the alveoli at the bottom than at the top because of gravity. Okay, and when you plot them together, which is what this is, they're plotting them both together, blood flow and ventilation in terms of liters per minute. Okay, so they've just plotted those same two graphs on the same axes. Okay, so there's our ventilation relationship from the bottom to the top, our blood flow relationship from the bottom to the top. Okay, interesting, they do not lie on top of each other. Right, the whole reason for doing all of this was to bring airflow in close proximity to blood flow. Okay, so they kind of match, but not completely. Okay, so we do have a region. If we think about how ventilation and flow relate, so if we think about what's called the VA over Q ratio, ventilation over perfusion. Okay, if we think about our ventilation perfusion ratio, it would be optimal if it were 1, where ventilation and perfusion were matched. Right, if this ratio was 1. Indeed, that does happen. At about rib number 3, we get optimal ventilation perfusion matching. At the bottom of the lung, ventilation is higher. Ventilation's high at the bottom of the lung, right? But blood flow is higher. So when you think about your VA over Q ratio, we did have an increase in ventilation at the bottom. That was for true. But we had a greater increase in flow. So we're going to have a decrease in our ratio, because we have more flow than ventilation down here. Okay, so we have more flow than ventilation at the bottom. At the top, here, we did have less flow, or less ventilation. We did have less ventilation up at the top, but we had much greater drop in flow. Okay, that's really just plotting these 2 points. So we're going to have an increase in ratio. Because we have a scenario where flow is less than ventilation. Okay, so if we're looking for an absolute optimized system, we do not have it across the lung. Obviously, we're doing fine, because we're all here today, breathing, oxygen's good, CO2's good, exchange is happening. All right, but note that it is not optimal. And key here is the introduction of this tool of ventilation perfusion ratio. Okay, so we're going to come back to thinking about using this as a tool to help us try to figure out whether ventilation is too high or too low, or whether blood flow is too high or too low. Because at the end of the day, the game is to try to match ventilation and perfusion. All right? Okay, so after all of that, we are not optimal. Around the 3rd rib, we're optimal, so life is good around the 3rd rib. All right, but we're not optimal, but apparently we're doing okay. And we will come back to the ventilation perfusion ratio in a minute. It'll help us. So let's step back for a minute and think about what we were trying to have an optimal ratio for. What was the optimal ratio for? Well, it was for exchange of gases between air and blood. So keeping our eye on the prize. What were we trying to do? Bring air in close proximity to blood so we could exchange gases using diffusion as a tool. All right, we could have an entirely different setup here if the system chose not to use diffusion as a tool. But because we chose to use diffusion as a tool, this is the system that we get. Okay? So critical about this thinking is, what are we exchanging? Okay, so just a real quick nip back to first year chemistries, biochemistries, all that kind of stuff. What are we exchanging? So obviously oxygen, CO2. So if we think about what we are exchanging with, so if we think about oxygen and CO2 in the air, that's what we want to bring in close proximity to our blood, right? We have a total pressure of all of the gases in the air, right? And those gases that make up the gases in air here: oxygen, CO2, nitrogen, and a bunch of other little stuff that we're really not going to consider because the body doesn't consider them. Okay? Other organisms might, we apparently don't. So this is atmospheric pressure, right? And so we have talked about atmospheric pressure being 760 millimeters of mercury here at sea level. Guelph is close to sea level. We're about 500 meters above, but good enough. So we have of that total pressure, part of the pressure is oxygen, part of the pressure is CO2, part of the pressure is nitrogen, and other stuff. Okay? So we get into what's called partial pressures. We talk about partial pressures of oxygen. We're talking about part of the whole. Okay? So in terms of the percentage of oxygen that it's in the air, it's 20.9%, so 21% oxygen in the air right now. Okay, so a part of this pressure is 29% of that 760, or sorry, 21% of that 760 is oxygen. Pretty much 0% of that 760 is CO2, and almost the rest of it, almost 80% of that 760 is nitrogen. Okay? Body doesn't care too much about nitrogen either. I just put it up there because it's the biggest number, but the body really doesn't deal with it. Okay? Doesn't regulate it, doesn't care about it. Okay? So if we think about what the partial pressure of oxygen of our total is, it's just 21% of 760. So we have a partial pressure of oxygen in the air of 160 millimeters of mercury. Okay? So that's where that number comes from. When it comes to CO2, 0.03%. The partial pressure of CO2 in the air is about 0.2 millimeters of mercury. We're really going to talk about that as 0. Okay, pretty close to nothing. Okay, so this is the air around us right now, dry air. Okay, it's not hydrated yet, it's dry air. Okay? So if you were breathing this air in, the dry air being brought in at the mouth would have 160 millimeters of mercury oxygen and about 0% zero millimeters of mercury CO2. Now we know once we bring that air into the lungs, we hydrated it. We added something to the part. We added something to the whole. We added water. We added water pressure to that. Okay, so part of the 760 at the level of the bronchioles is now water. Okay, so we have to take that water away now from the partial pressures that we calculated. Okay, because now part of the 760 is water. We didn't use it in the calculation out here because it isn't a whole lot in the air out here. Okay, but now we have to consider it once you head into the bronchioles because that's about to be what goes into the alveolus. Okay, so part of the partial pressures of the gases going into the alveolus, part of that pressure is water. Okay, so we have to remove that amount. Okay, about 47 millimeters of mercury. We've got to remove that amount from what our partial pressure was and then recalculate So now it's 21 so in terms of oxygen, what is our partial pressure of oxygen? It's 21% of that new calculated total. Okay? So in terms of what's coming into the alveolus, in terms of partial pressure of oxygen, it's a little bit lower, about 150 millimeters of mercury. CO2 about the same as it was before, about 0. Okay? So this is because air is hydrated by the trachea and bronchi. And it's to the tune of 47 millimeters of mercury. Okay? So we remove that from our atmospheric and then recalculate so that we have about 150 millimeters of mercury PO2 and 0 PCO2 entering the alveolus. Okay? So hopefully that is what we're bringing in. At the end of the day, though, that is not what is in the alveolus. Okay? That's not what we find in there. And we'll take a quick break, and we'll get back to why we don't have these gas concentrations in our alveolus. All right, so let's think about then. So we think that at the mouth we're bringing in 160 millimeters of mercury oxygen, 0% CO2 or 0 millimeters of mercury CO2, and then we adjust that because we hydrated the air. So entering the alveolus, 150 millimeters of mercury, PO2, 0 millimeters of mercury CO2. But that isn't what is in the alveolus. Okay, so let's think about that for a minute. Let's draw a little focus on a little alveoli here. So I've got my little alveolus and I've got my blood flow that's going by. Okay. We want to know what's in here. That's what we're trying to figure out, what we're exchanging, right? What's in there. Okay, so we talked about the dry air at the mouth, and then we would bring that in and hydrate it so that coming into the alveolus we would expect a PO2 of 150 millimeters of mercury and a POCO2 of about 0 millimeters of mercury. Okay, but again, that's not what we're going to find in here. Okay, and so we got to think about why that is. So critical is to add now on to the argument that indeed we will bring something in here, and we will be exchanging CO2 with oxygen. Okay, that's really was the whole reason for all this. That we do have. So let's think about the blood that's coming by. Okay, so we've talked about what we think the air might be coming in. Let's think about the blood coming by. All right, so we have the right heart bringing blood to the pulmonary artery, past the alveolus, out into the pulmonary vein, right? Down to the left heart, into systemic arteries. Okay. Send out to the tissue, capillaries, back to veins. That will deliver blood back to the right heart, back to the pulmonary artery, et cetera, et cetera. Okay, so a little snapshot as to where we're at. In terms of the systemic venous partial pressure of oxygen and CO2, so partial pressure of oxygen in the veins is going to be 40 millimeters of mercury. Partial pressure in the veins of CO2 is going to be 45. Okay, so that's blood that's been by tissue already, and that tissue has taken oxygen away and put CO2 into the blood, right? So we have a low oxygen, high CO2 scenario in the systemic veins. That blood then is being delivered to a pump. Okay, so that pump is just pumping it. The right heart is just pumping it, moving it from systemic veins up to pulmonary arteries. So the PO2 and the PCO2 up in the pulmonary arteries should be exactly the same, because nothing changed it along the way. All we did was feed this blood into a pump that shot it into the pulmonary arteries. The same blood got moved into the pulmonary arteries. Okay, so we would absolutely expect that the partial pressure of oxygen in the pulmonary artery is going to be 40 millimeters of mercury, and the partial pressure in the pulmonary artery of CO2 should be 0. Okay, it's the exact same as what's in the systemic veins, right? Because all we did was push the blood through a pump. Okay, so that blood now moves past our alveoli. Exchange occurs, right? We unload CO2. There'll be a, wait, that's not 40, this is 45. We have high CO2 in the blood, low CO2 in the alveolus, so we would move CO2, would diffuse down its concentration gradient. We would have higher oxygen in the alveolus, lower oxygen in the blood, so oxygen would move down its concentration gradient, right? So we're constantly exchanging here. So as we exchange, when we look at what pulmonary venous blood has in it, okay, pulmonary venous blood, so partial pressures in the pulmonary vein of oxygen is going to be 100 millimeters of mercury as we picked up oxygen. And partial pressure, careful here, pulmonary vein CO2 is 40 millimeters of mercury. Okay, so we picked up oxygen, got rid of CO2, so in our pulmonary veins we have high oxygen, low CO2. And then we take that blood and we feed it to a pump, left heart, and then send it out to the systemic arteries. So there should be no difference between the concentrations of oxygen and CO2 between the pulmonary veins and the systemic arteries. We didn't change anything, we just fed it through a pump. Okay, so in our systemic arteries, we should fully expect to see partial pressures of oxygen in our arteries being 100 millimeters of mercury, and partial pressures in our arteries of CO2 being 40. Okay? Make sense? So we can't entirely predict in here what is going to be in here because we are constantly exchanging. Right? So if we are to take a snapshot of what is going on in the alveolus in terms of what oxygen and CO2 are there, it's difficult to predict. It is going to be lower than 150 millimeters of mercury partial pressure of oxygen, and it's going to be higher than 0 millimeters of mercury partial pressure CO2. Okay? And in fact, partial pressures of oxygen in here are 100 millimeters of mercury, and alveolar CO2 40 millimeters of mercury. Okay, so if you look at these numbers, you can tell that what we're looking at here, because the partial pressures of oxygen and CO2 in the alveolus are the same as the partial pressures of oxygen in the pulmonary vein and CO2 in the pulmonary vein, that what we are looking at here is post-equilibrated numbers. Okay, so these numbers have already been equilibrated with the blood. And the trick here at the level of the lung is it's hard to get a measure of alveolar oxygen or CO2 because it is always equilibrating with the blood. But we do know, what this does tell us that is that blood always spends enough time at the alveolus to equilibrate. Okay, so this is a really key idea. So really critical is blood always spends enough time to equilibrate. Why is this so critical? Well, what this tells us is that the equilibration time arguments that we messed with at the kidney, right, change flow, change equilibration time, they do not apply here. Because the system is set up with that massive amount of flow or a massive amount of capillaries around every alveolus, that equilibration time arguments like we messed with in the kidney do not apply here, right? So really critical. If you go back to your cardiovascular mechanics examples that we took, we were changing flow across the pulmonary system all the time, right? When we were trying to predict, we messed with the cardiovascular system when we were trying to predict the 4 artery and venous compartments. We argued all the time, we're going to change, if we had a high pressure in the pulmonary arteries, we would increase flow across the pulmonary system, right? Increase flow across the pulmonary system. Okay, increase flow across the pulmonary system. Okay, you've been doing it for weeks and weeks and weeks, increasing flow across the pulmonary system, right? So we are going to have to figure out how that affects oxygen and CO2 without a doubt. But equilibration time is not the go-to argument here, okay? Blood always spends enough time to equilibrate with the alveolus. The other key thing that this really means is if blood always has enough time to spend, then we can predict. If we can predict what is in the alveolus, we can predict what is in the pulmonary veins. So the game afoot with the lung is predict what is the partial pressures of oxygen in the alveoli. Partial pressures of oxygen and CO2, or partial pressures of CO2 in the alveoli, because then we'll get here. Okay, but let's think about this number again for a minute. Let's back up and say, okay, so why is this number, why is partial pressure of oxygen in the alveolus not 150? And why is the partial pressure of CO2 in the alveolus not 0? Okay, a couple of reasons here. I kind of made a mess of this. I'll grab another piece of paper. These numbers are also all for metabolic, basal metabolic rate. Let's jot that down too so everyone's happy with the numbers we're talking about. So the numbers that I've thrown out here are for basal metabolic rate. So no, you're not exercising, you're just kind of sitting, okay? So let's then think about the question, why is PaO2 not equal to 150 millimeters of mercury? It's actually less. And why is PaCO2 not 0? It's actually more. Okay? So first of all, we talked about that idea that oxygen, we are continually having flow, so we are continually equilibrating. Okay? It's hard to get a snapshot. So oxygen is always being continually removed by blood. And conversely, CO2 is being added. Okay, so that's if we were, what would be going on if we were sitting in the alveolus. Oh, dang it. The second is residual volume. There was always a residual volume in the alveolus. We didn't bring in 100% new fresh air, did we? We didn't bring in a whole volume of new fresh air. There was always that residual volume sitting there. And that residual volume has been sitting there equilibrating with blood the whole time. Okay? So this is really, we're mixing this new air we're bringing in with previously equilibrated air. Okay, so here this residual volume is air in the alveolus that was not expired. Okay, so that's why CO2 is going to be higher and oxygen is going to be lower. And there is a third reason, and we will talk about it on Friday, lecture on Friday. Okay, guys, have a good one.